Hey everybody, I am so proud to introduce this fantastic episode, number 6 of the Cribsiders. While it is a pediatric medicine podcast, on this episode, they delve all into the diagnosis and management of type 1 diabetes with a fantastic guest. Whether you're a pediatrician or an internist, this episode is going to be very relevant to your practice. But before we get on to the show, I just wanted to give a really quick shout out. If you are interested in academic medicine or just want to master a clinical skill, consider a 1-year fellowship in clinical ultrasound at the University of Pennsylvania. They have graduated 8 non-emergency medicine POCUS Fellows, and you could be the next one. Check out pennultrasound.org. That's PENN ultrasound.org, or email nathaniel.reisinger@pennmedicine.upenn.edu.
Continuing education credits for physicians and other healthcare professionals is provided by VCU Healthcare Continuing Education. Check out cribsiders.vcuhealth.org for more information.
The Cribsiders podcast is for entertainment, education, and informational purposes only. The views and statements expressed on this podcast are solely those of the host.
Welcome back to the Cribsiders, everyone. We are joined tonight by a great cast. Our outstanding guest, Dr. Hussein Abdullatif, and our phenomenal assistant producer, Shannon Snellgrove. Before we talk about what we're talking about today, Chris, can you tell us what the show is about?
We are the Pediatric Medicine Podcast. We interview leading experts in the fields to bring you clinical pearls, practice-changing knowledge, and answer lingering questions about core topics in pediatric medicine.
And today we had a fantastic conversation with our guest, Dr. Hussein Abdullatif, more commonly referred to as Dr. Latif, or throughout this interview, Hussein. He was wonderful. He is a pediatric endocrinologist and professor in the Department of Pediatrics at the University of Alabama School of Medicine in Birmingham, Alabama. He is a dedicated clinician educator at UAB by serving as co-director for the Pediatrics Clerkship, through which he is the recipient of numerous teaching awards. Dr. Latif teaches us how to appropriately diagnose and work up new onset diabetes, as well as how substantial diabetes education can really be a mainstay of treatment. So, without further ado, let's get to it.
This will be a sweet episode.
There it is. So, Hussein, thank you so much for joining us. We're very excited to have you. And let's just start with a couple questions. Do you mind telling us a little bit about yourself, describing yourself in a one-liner like we often do with the patient?
Oh, God. I'm Hussein Abdullatif. I'm a pediatric endocrinologist in Birmingham, Alabama, with University of Alabama at Birmingham. I came to medicine because my father wanted me to. I wanted to be a historian or archaeologist, and I still am interested in that. So I'm a humanist at heart. A little crazy. I still think that I'm young when I'm not.
What is your favorite failure, and how did you learn from it?
So, I grew up outside the United States. And so in the 80s, in order to come to the United States and train in pediatrics, I had to pass the exams that were equivalent to step 1 exam. And my confession is that I actually failed that equivalent to step 1 maybe 4 or 5 times before I passed it. So it's my favorite failure because I really lost hope of ever coming to this country, and then eventually I passed it. So, and it humbles me when I am advising students who are challenged with step 1 scores or are challenged with step 1 passing and stuff like that, because I've been there and I turned out okay.
You certainly did.
Absolutely. I love stories like that. I think everyone has a very humbling story of how they got to where they are. And it's always very reassuring, especially as a student or trainee when you're having struggles or have little dips in your career, to see people that have become so wildly successful and have overcome those little blips.
Yeah.
So kind of along those lines, one of the questions I always like to ask is about advice. Can you share some advice that you received either as a teacher or as a learner that you feel is nice to share?
Yeah. One of my teachers in medical school, he always was saying that students actually have more knowledge than their teachers. but students do not know how to put that knowledge together. And that was something that always stuck with me as a student, is that like maybe I need to see how things fit together rather than just know it and know it and know it. And it helped me as a teacher to advise my students not to be afraid to make mistakes, to say what they think. As long as they can defend it and be reasonable about it, then that would be my advice as a teacher. My advice as a teacher to students, to not be afraid to speak up.
I love that.
Excellent. So, Justin, do you want to do some picks of the week? I don't know. We've done picks of the week.
We haven't done. I think if we do them, we should do them quick. You got anything good? You got what are you reading, Chris? What are you watching? You got any big tips for the fans?
Well, let me think for a second, because I only brought it up without even coming up with one. Do you happen to have one?
Yeah, sure. I got one we can share quickly, and then we'll jump on. So I wanted to say this one for Paul, because I think he would love it on the Curbsiders, but we'll share with him. But there's a Netflix special, John Mulaney and the Sacked Lunch Bunch, which is a nice, I think, pediatric thing. It is John Mulaney, a comedian, with a handful of child actors. That is a very confusing, very kind of avant-garde musical sketch show that is, as he described, kid programming by adults for adults. It has David Burns from the Talking Heads doing a musical with a 9-year-old. It's weird, but
did you see the SNL episode he was on?
No.
Oh, it was good. Yeah, David Burns, and I think John Mulaney was actually on.
I think they're buddies. Weirdly,
So that's my pick of the week. Then how's that? People go back and find that SNL episode. John Mulaney.
I'll have to check it out.
It's worth watching. Be prepared. It is unique. It is art. All right, so let's jump right in. What a great segue, talking about the Sacked Lunch Bunch, to talk about the Sacked Lunch Bunch at Cashlet's Pediatric Primary Care Clinic. So, Hussein, if you'll walk us through, we have a patient for you. It's a 6-year-old boy. He presents to the clinic. Mom reports he's been pretty tired for several days. She's also concerned that she's noticed that he's had some bedwetting in the past month, which is totally new for him. He's lost about 6 pounds since his last clinic visit 3 months ago, and he appears thin, but otherwise has a pretty unremarkable exam and has normal vital signs. You are a little concerned about diabetes, given the weight loss, given the bedwetting, and given the fatigue, and sure enough, a random glucose is 277 and a point of care A1C is 10.5%. So can you walk us through, can we say for sure this patient has diabetes, and what is the diagnostic criteria for diabetes in a child?
So, and those are things that change and have changed for a while. One of the diagnostic criteria for diabetes is to have a hemoglobin A1C above 6.5%. And so by having a hemoglobin A1C of 10 point something, that definitely falls into the diabetes. In the past, we used to say hemoglobin A1C cannot be used as a criterion for diagnosis of type 1 or type 2 diabetes, probably mainly because if you have a low hemoglobin A1C, that does not exclude the possibility of diabetes, but not a high one. And so now 6.5 and above would be. The other areas that we use are a fasting blood sugar above 126 or a random blood sugar above 200 milligram per deciliter. This would fall under a random blood sugar of above 200 milligram per deciliter. Now, if we want to use that criterion, we want to repeat it. You don't want to use one number, and especially if it's a point of care glucose, you may want to have like 2 numbers or 3 to make sure that this was not a lab error or a machine error of some sort.
Now, is there a specific spacing in which you need to repeat that? Can you repeat that within, like, you get your first lab, you're like, oh, I want to repeat it, and you repeat your second lab, or are you supposed to space it?
I would say not necessarily, because like a number like this, if it's really persistent and present, you would do it. If you do want to space it, I would space it a half hour or an hour or something like that. But then you'd worry that maybe it did actually go high to the 200s and then went down. If it actually did go that number, then it's diabetes still.
And so I always wonder, if I were to eat a ton of cake, if I just ate a whole apple pie to myself or was drinking, sugary drinks, I do not have diabetes. I will not be able to get my random glucose above 200. Is that the idea for the diagnosis?
It should not go above 200. And so when we go to standardized testings, for example, we do the 2-hour postprandial or 2-hour post-glucose. And what we usually look at, if the blood sugar is above 200, then it's a diabetes at the 2-hour time. And if the blood sugar is between 150 to 200, then that would be pre-diabetes, glucose intolerance under that category.
Excellent. And so for this patient who's come in with fatigue, weight loss, and bedwetting, is that the common presentation for type 1 diabetes? How do we often find these children? Are they presenting in DKA, or what's the common presentation for new type 1 diabetes?
Really very good question. It can be different kinds of presentations. And this is for a regular kid, a kid who's above 2 or 3 years old. It would be mostly fatigue, polyuria, polydipsia, hunger, eating, and generally looking skinny or having lost weight over a certain period of time. They can present with DKA, diabetic ketoacidosis, which can present with vomiting, nausea, abdominal pain, and maybe in addition, it changes in the level of consciousness, being a little bit tired and fatigued, and also talking a little different. There are some situations where the family is just very vigilant, either because they do have other members of the family that have diabetes, so they may be checking blood sugars a little bit too often or dipping urine because they are worried that their kid can develop diabetes. Our aim as a community of pediatricians is to try to not catch anyone presenting with diabetic ketoacidosis, because that is a dangerous thing to have, and to educate the public and the pediatricians to pay attention to other symptoms of diabetes. So kids will come not coming to the ICU or situations where they need extra help.
Now, so if I was this boy's parent and, I'm bringing them to either, the office and we've gotten a couple blood sugars, or maybe they're even sicker and they show up in the emergency department and we get these labs, a lot of parents, there's a lot of confusion between, what's type 1 diabetes, type 2 diabetes, especially for the older adults. They know that, Uncle what's his face has, diabetes. Is that the same thing? How do you explain it to a parent?
Yeah, before I explain anything to the families, I start with two very important messages that I need to let them know when someone is diagnosed with diabetes. And the first one, oftentimes families come with a sense of guilt and or blame of some sort. I start with saying it's not anybody's fault. It was something that was happening, that's happened, and they couldn't have done anything to prevent it. And my other point that I tell them is they may have had or they may have seen pictures of people who had diabetes who had a very difficult outcome and lots of side effects of it. And I assure them that the future is much brighter for so many different reasons. So that's kind of the first statement I would open my mouth with. And then we talk about the differences between type 1 and type 2 diabetes. Although, generally speaking, the most important question to me when a child comes is not necessarily are they having type 1 or type 2 diabetes. The most important question is this a kid that needs insulin or not need insulin, no matter whether it's type 1 or type 2 diabetes. So I will tell them, this blood sugar and this hemoglobin A1C that we're having, we have to use insulin in this child at this moment. And then we will talk a little bit more about type 1 versus type 2 diabetes and the difference between them. And then we proceed into type 1 diabetes. You don't have insulin. Insulin is the key that gets the glucose inside the cells. And so if you do not have the key, the glucose stays outside the door, and then they will flood the gates and it will flood in the urine and, all that kind of stuff. You probably heard that story before, or many people have heard that. That's kind of the traditional way of explaining diabetes to parents. Type 2 diabetes is a little harder to explain because it's not an issue of a lack of insulin, but it's a relative lack of insulin for the need that the body has. So in order to develop type 2 diabetes, your body is requiring more insulin, but your body is unable to produce the extra amount of insulin, and therefore the glucose is not getting inside the door and we're flooding the system again. Sometimes I worry when the families are asking about that issue is that because they really want to avoid an injection, which is insulin, and they prefer to have type 2 diabetes over type 1 diabetes. I try to explain to them that type 2 diabetes is not necessarily better or worse than type 1 diabetes, and in some ways it may be much worse, in some ways it's better, but taking insulin is not such a big deal. Although at the beginning, having to give your child an injection is associated with feeling of guilt and sorrow and regret of some kind.
Yeah, that's great. I guess my follow-up question would be, usually when I'm talking to a parent about newly diagnosed diabetes, another question they often has like, well, so my aunt or I or my grandfather, they have diabetes, and they may not know the differences between the type. They often will ask, well, now are all my kids predisposed to diabetes because of this family history of diabetes? Is it the same, obviously?
Certainly, the family history part is stronger if you do have type 2 diabetes than if you do have type 1 diabetes, but certainly there is a very strong genetic component to type 1 diabetes. So our traditional answer to that kind of question is that the risk to having type 1 diabetes is 1 in 500 in the general population in the United States. But if you do have a family member, a close family member with type 1 diabetes, then the risk becomes 1 to 50. So it becomes like 10 times more. Now, if it is a situation where you have identical twins, one brother or sister who is an identical twin, what's the risk for the other sibling? Then it's about 50%. So it's a much higher, it's not 100%, interestingly, but it's 50%, which is high enough.
I love the lock and key analogy. I've never heard that, with insulin being the key to open the door to the cells for glucose. And I like that imagery a lot. I'm going to use it now.
I learned sort of a variation of this where like glucose is like gas in the car, and using the key to turn on the car. You can't use the gas in the car unless you have the key to turn on the car. So it's something very similar.
Yeah, insulin's definitely the key, though. And so let's say with this patient, we have the patient in front of us in clinic. And as a primary care doctor, I do a great job of explaining to the parent that the insulin is the key, and we're going to get them set up with an endocrinologist. But in the meantime, are there other things that I should be doing as part of the initial workup for a new diagnosis of diabetes? I feel like I've often checked for thyroid disease, celiac, and should I be ordering the common type 1 diabetes antibody tests? And if so, which ones? Because there seems to be a handful, and I'd love some guidance on what I'm looking for, what's the best, and if this is truly necessary.
Well, that's really interesting. I mean, really very, very good question. And like as a primary care physician, it may depend on where you are located. Like, are you a primary care physician that's in a good distance away from a big city or a big center that may cater to someone who has diabetes, where you will have to depend on your own care for your patients and therefore become much more autonomous in caring for diabetes. So what we order, and I never discourage a primary care physician from ordering them themselves, certainly, because I like to empower my primary care physicians to take care of their patients as much as they can. So the antibodies that we order are glutamic acid decarboxylase 65 antibody. That's always ordered. Is some form of islet cell antibodies, and it could be an ICA512 or an IA2 antibody, anti-insulin antibody. And the third one that we are starting to order more of is anti-zinc transporter 8 antibody. Why do we order 3 antibodies? The reason for this is that the more antibodies you order, the more the likelihood that you'll have them positive in someone with type 1 diabetes. So if we do order those antibodies, then we'll catch 90% of the people with type 1 diabetes. There is a 10% who have what we call type 1 diabetes, but they are negative in antibodies. So the negative antibodies does not exclude the diagnosis, but it makes it interesting, as in, do I need to keep in my mind that this could be a new form or another form of disease that acts like type 1, but it may not necessarily be a type 1?
And as far as the different antibodies, are there any different phenotypes if someone is anti-GAD65 versus anti-islet cell, or if they're pan positive, is that like, oh boy, they're going to have a lot of trouble with their diabetes, or is this just a catch-all?
Probably more like a catch-all. Now, there are some studies that are showing that the zinc transporter 8, if it's positive, then you lose your reserve of islet cells about 20% much faster.
Wow.
Yeah. Now, there was a traditional picture that if someone is a little bit skinny, then it's type 1. But if you're a little bit full, big boned, we call in the South, then maybe you have type 2 diabetes. That's not necessarily true. So sometimes we get someone who's full and they have type 1. So now kids that look like type 2, we check antibodies on. And people that look not 100% clear, we look at a C-peptide level just to see if it's lowish, highish, to give us an idea eventually in the future of how to navigate this kid.
Can you explain a little bit more about the C-peptide?
So C-peptide is a cutoff part of protein. That is, when we produce insulin, we have the pro-insulin molecule. And the pro-insulin molecule is a bigger molecule. And before we secrete it, we cut off part of that molecule. One of them is called the C-peptide, and the other one is the insulin, which is the active component. The C-peptide is a marker for our innate production of insulin that we have in our system. So if you have it positive, that means your body is producing insulin, versus if you have insulin positive in the body, but no C-peptide, this could be because you took it. You took it as injection or through other sources.
This is great. This is really, really helpful. I've seen in the initial workup, in addition to these antibodies, is screening for concurrent autoimmune disease like celiac and thyroid. Are there other things we should be looking for in these patients that have presumed type 1 diabetes?
That's a really very good question. That is what we actually do when we diagnose them. We screen for thyroid and celiac disease. The one thing that I fall into error with is if they do have more than one autoimmune condition, like, diabetes and thyroid, or diabetes and celiac, or diabetes and celiac and thyroid, then I do need to not miss a possibility of Addison's disease, especially Addison's disease, because that's a condition that hides, and unless you think of it, you will miss it until they really come very sick and maybe coming to emergency rooms. So that's one autoimmune condition that I really don't want to miss. The other is that they are at risk for rheumatoid arthritis. They're at risk for inflammatory bowel disease, not celiac. So if they are coming with gastrointestinal symptoms and they are celiac negative, that doesn't necessarily mean that they don't have other issues with their GI symptoms, and therefore I need to keep that in mind.
I had a patient once that did have thyroid disease, diabetes, and Addison's, and that's a syndrome. Is that correct? Like an autoimmune polyglandular syndrome? Is that
yes.
Is that the correct? Yeah.
Now, to piggyback on some what you sort of described and other things you're screening for. Now, there can be atypical presentations for those who present with diabetes, as well as maybe even presenting with those other diseases first and then diabetes afterwards. Is that correct?
Correct. I mean, you can start with thyroid disease and then you end up with diabetes, or you can have Addison's disease and then you will have diabetes. So it certainly doesn't have to come diabetes first and then the others. Now, when I hear like atypical presentations of diabetes, lots of things come to my mind. One of them that is very, very important to keep in mind is that someone who's younger than 1 year of age, when they present with diabetes, they can present as a picture of sepsis. This is one tricky condition because they come to the emergency room, for example, and they look very sick and they look very dehydrated. Diabetes is not the first thing that comes to people's minds, but it could be a diabetic ketoacidosis. And so the emergency room doctor needs to be very vigilant and to pay attention to the possibility of diabetes. Sometimes those kinds of kids, when they come, they have a little bit high blood sugar, and it will be dismissed oftentimes. Well, this is part of stress, and stress can raise your blood sugar. And so, but keep in mind that can be diabetes. So that's one plug I don't want people to miss. Now, diabetes is not only type 1 and type 2. So you do have what we call monogenic forms of diabetes, which can present either at birth, and that's what we call neonatal diabetes. If you do have a kid presenting with diabetes before the age of 6 months, then we do need to check their genetic background to look for the different genes that are associated with diabetes. It certainly could be still type 1 diabetes. It can present that young. But then if it is presenting that young, then they do have a very strong autoimmune issue. And there are some monogenic autoimmune disease situations that we may need to pay attention to. So that's one. And the other thing to think about is that if someone had pancreatitis, we do have a good number of kids with type 1, insulin-dependent diabetes as a product of pancreatitis that happened because of hemolytic uremic syndrome. Or it can come because of a storage disease like hemochromatosis or cystinosis or those kinds of things. There are people who have what we call MODY, or the original name is maturity onset diabetes of the youth. And this is kind of a monogenic inherited diabetes, usually much milder, doesn't present with diabetic ketoacidosis. I do remember we had a medical student one time who came to us and said that people told me I have diabetes, when actually what she had was MODY, a very mild form of diabetes because she looked very healthy.
So how would you differentiate MODY versus the other types of diabetes?
Yeah, they generally would have MODY would be like a monogenic diabetes, so it would have a much stronger family connection than type 1 or type 2 diabetes. So they will have that kind of family connection, and they usually will have a milder form of diabetes, or they will come to you and they look very healthy, very lean. There's nothing about them that says, yeah, you have type 2 diabetes. They say, well, I have type 2 diabetes. Well, God, you don't smell type 2 diabetes. So the more you think about it, the more you diagnose it. So the more in our practice, we're testing more and more for it, and we're discovering more and more people with, in between quotation marks, have type 2 diabetes that actually have the MODY.
So the patients with MODY, I presume, are antibody negative.
Correct.
So you would do the antibodies. And are they insulin dependent or often not because it's mild?
Yeah, often not. Very few of them are insulin dependent. So they are antibody negative. They're producing insulin, and they don't have the phenotype that you would expect for a young person to have diabetes. Got it.
What's our typical age group for presenting with type 1 diabetes? It can be as young as a baby, which is not something I've seen, but how old? When are we out of the woods of a type 1 diabetes diagnosis?
Yeah, so there's no age for type 1 or type 2 diabetes. We've seen type 2 diabetes in people younger than 10 years of age, and people can have type 1 diabetes from birth to old age. And that's a very important message maybe for an internist that may be listening to this, or a med-peds person, is that I personally diagnosed fathers of children that came to us with type 1 diabetes, diagnosed their fathers as having type 1 diabetes when they were told that they have type 2 diabetes. That the kid came presenting with their newly diagnosed type 1 diabetes. And then I look at the father and he said, well, I have type 2 diabetes. And I'm like, no, you don't. Let's check your antibodies, and certainly their antibodies come back positive, and they were type 1 but misdiagnosed as type 2 diabetes. When type 1 diabetes occurs in older people, like maybe young adults to middle age to older age, it's much slower progressing to becoming insulin dependent than the type 1 that occurs in a child. And so that makes it easier for people to make a mistake of diagnosing them as type 2 diabetes, because they are not yet becoming very insulin dependent. But it's also dangerous because they become ketotic eventually if you don't catch them in time.
So back in our clinic, let's say we've done an appropriate referral, and now the patient is in your office. We've talked a lot about the diagnosis of a patient with type 1 diabetes. So now let's talk treatment. When you are explaining to a patient or a parent about how we are treating diabetes, how do you approach that discussion, and how do you choose the treatment regimen. What are you using? What's the treatment goals? Can you give us a little bit more details about the treatment plan?
Yeah. So we're talking type 1 diabetes or?
Type 1 diabetes specifically, please. Yeah.
So for type 1 diabetes, the treatment plan is what we call basal bolus regimen. And so what that means is that they have to receive two kinds of insulin. One insulin that is maintaining a level of insulin in your system for 24 hours somehow. And the other system is to give a bolus at the time of eating or at the time when you have a high blood sugar level. So that's the basal bolus. And this covers injections and it covers an insulin pump regimen. In general, there are some places in the country that may start a kid with type 1 diabetes on an insulin pump right away, but that's not many. Most places will start them on an injection process, and for very good reasons. One of them is that if you're on an insulin pump, it can fail, and therefore you really need to know how to give injections and how to manage injections in case of failure of your pump. So we'll have to give them the two kinds of insulin. We say the basal insulin would be this long-acting glargine versus detamir versus Tresiba, diglut something. So those are ones that were given like once or twice a day, it could be. And then you'll have to give them the bolus. And then we'll go about teaching them about the bolus, meaning it has to be associated with meals or snacks. And we'll teach the families how to count the carbohydrates and come up with a formula of correcting the insulin dose according to the grams of carbohydrates that they're eating, and also correcting the insulin dose by their blood sugar level, and what they want to come down to. So this is the main area of our education, is teach them the different types of insulin, teach them how to count the carbohydrates, teaching them the formulas that they are going to use, in addition to teaching them how to give injections and how to check for low blood sugars and high blood sugars and manage them accordingly.
Now, do you ever run into, I've definitely, we've all had our fair share of patients and parents or families who are just incapable of doing the complexities that are involved with carb counting and then even doing the simple calculations. How would you approach some of those families?
Yeah, and we adjust it according to the needs of the families. And I think what we found out is that oftentimes families are under extreme stress and extreme shock, that at the time having the calculations is not the ideal thing, and maybe they will be ready for it later, a month or two later or something like that. And we've had that kind of success. If we are to do it this way, then we go to a set dose of insulin. But as you do a set dose of insulin, then you'll have to teach them with the diet that they have to eat a particular amount of food. So you become a little more rigid with the food, less flexible, but you also help them with being on the set dose of insulin. And then you also give them what we call a sliding scale, where you give so-and-so extra units for blood sugar between this number, and then adjust it accordingly. So that way you're taking the math out of there. But I like to think that this is more of a temporary thing, and that in the future they will be able to have the calculations and will move farther. And the vast majority of people that we started with this regimen end up eventually doing calculations beautifully.
I'm really excited that you brought up diet, because this is something I have a lot of questions about. When you have a new type 1 diabetes patient or patient with type 1 diabetes, how do you counsel the dietary modifications? And do they need to have dietary modifications? Is there any reason someone can't eat 4 donuts and then give the appropriate insulin based on the carbohydrates?
Ooh, very good question. I mean, and you may get me in trouble with some nutritionists with my answer. So in general, the only diet modification that I advise is that they should avoid sugar drinks. So other than that, I do not advise them to change anything of their patterns of the diet. And I am not exactly right in that there are some other nuances of diet, but I don't want them to be overwhelmed with nuances of diet right away. So basically to them, I would say your only adjustment is that you will have to avoid the sugar drinks. And your other adjustment is that you'll have to learn how to count the carbohydrates in the food that you're eating. And if you're counting the carbohydrates and you're able to do the calculation of the insulin to carb ratio, then you're great. You do it, you go eat cake, you do whatever you want to do. You can even eat those 4 donuts. But if I say that in front of my nutritionist, she will kill me.
I think that that's super helpful. And I think it comes up a lot on the inpatient side when we admit a patient that happens to have diabetes, whether to give them a carbohydrate restricted diet when we're very closely monitoring their blood sugar and sliding scale insulin. For these patients, is it fine to order a regular diet and just make sure to...
That's what we usually do, and we order it. Now, talking about the low carb diet, and there was a study that came up maybe 2 years ago, and there was a very interesting article that came in the New York Times written about that article, where people between the age of 13 and 39 were put on a low carb diet, meaning they're eating about maybe 30 to 50 grams of carbohydrates a day, and they have type 1 diabetes. And they reported that they have very good control, meaning they don't have spikes of blood sugars that go high and drops that go low. And the reason for this is that you're not challenging them as much with the bolus, and you're basically having to keep up with the basal insulin as well as you can be. As pediatricians, I worry about ordering low carb diet or way too low, because then you start worrying about getting into ketosis, not related to lack of insulin, and then that becomes confusing, and whether it will affect growth. That study was not done on a very young, it was done on people who are 13 and reported that there was not an effect on their growth. But if a family comes to me, and families are very well educated that are dealing with type 1 diabetes, they will come and say, well, I'm interested in a low carb diet. Then I would tell them, then you may want to limit it, but not limit it to like 30 to 50 grams, maybe limited to 50 to 100 grams or something like that, a little bit adjustment to that diet. This is more like diabetes 102 rather than, or 103, or, God knows what. Most families that try it eventually don't stick with it, because it's really difficult to stick with regimen, although people do stick with it, who have very strong will.
We're sponsored by Pediatrics On Call, the new podcast from the American Academy of Pediatrics. Each week, hear the latest news on children's health with advice and tips for doctors and parents alike. Subscribe to Pediatrics On Call and visit aap.org/oncall.
Now, you sort of threw out some numbers in terms of what you consider sort of low carb. For especially some of our learners who are listening, maybe some med students and interns, residents, or other people listening, can you sort of describe exactly what a carb is and maybe some general rules of thumb of what that might look like?
Carbs, bread, rice, corn. So those are like, our big sources of carbohydrates. But then there will be carbohydrates in other foods that we do not think of. For example, like beans have lots of carbohydrates in them. If you're a vegetarian, in general, you're eating a good bit of carbohydrates in your diet, because beans and rice and all those kinds of things would have it in them.
When someone's trying to count a carb, like what equals 1 carb or 2 carbs?
So you're bringing up kind of the question, a carb. So traditionally, like, this comes from the nutritional background, and it can be very confusing at times, because to some people, a 1 carb is a 15 grams of carbohydrates. So that is the traditional way of teaching nutrition when we were doing with servings, and the serving would have 1 carb, 2 carbs, with a 1 carb is a 15 grams of carbohydrates. Now, when we move to counting carbohydrates, we're saying it's really the counting is how many grams of carbohydrates, is not by 1 carb, 2 carbs, 3 carbs. And so that's where sometimes error and confusion happens. When I say 1 carb, is it 1 gram am I meaning, or am I meaning 15 grams? When we go to bread, for example, like a toast of bread that's the size of our palm, is a 15 grams of carbohydrates. If we're looking at a carton of milk, a small carton of milk, that's about 20 grams of carbohydrates in it. A half a banana is a 15 grams of carbohydrates. A small apple is a 15 grams of carbohydrates. And so those are like for people who are using measures of things that are not provided to them directly. Now, if you go and eat at a restaurant, especially a fast food restaurant, then they have the exact amount of carbohydrates in every meal that they are eating, although they may not announce it, on their menu and things like that. And if you buy anything in the store that is pre-prepared food, then you will have the grams of carbohydrates in it.
I would have ruined my low carb diet restrictions through breakfast with those calculations.
Yeah, I like what do you eat?
So my next question is, how often are you recommending them checking their sugars? And are there other types of goals in terms of these sugars or even A1C that we're looking for as we move forward with treating this patient?
Great question. So we do ask them to check blood sugars before each meal and before bedtime, and sometimes to check it at 2 a.m. in the morning, or at least in the beginning at 2 a.m. in the morning, in order to make sure that we're not dealing with low blood sugars in the middle of the night. Every now and then, we may ask them to check blood sugars 2 hours after the meals, more in order to see if their bolus that they're giving is appropriate or not. So that's kind of the traditional teaching that we say. And they take insulin before each meal and probably also before each snack that they eat. We do tell them about what we call a range of blood sugars. And the range of blood sugar, the aim for this range is to help empower them to know if their control of the diabetes is ideal or not yet ideal. So what we say, we want the range of blood sugars to be between 80 and sometimes 180, sometimes 150, sometimes 120, depending on the age of the child and how recently they were diagnosed. And then what we say, this is the range that we're aiming for, but that doesn't mean that I'm going to give you a hard time if you are falling outside that range. This is a range for us to look at the pattern of blood sugars, and we want to have 50% of the readings in that range. If the 50% of the readings are not in that range, then that means it's time for us to make an adjustment to something in order to bring it down to that 50%.
And so, generally speaking, when you're doing your tweaking of your insulins, I think you said a little bit. So you either preprandial or 2 hours postprandial, you're checking your sugars and maybe titrating your bolus dosing based on that. And I assume then you're fasting in the morning. That's what you're using to titrate your basal. Is that correct?
You do use the fasting blood sugar to titrate the basal, but sometimes not necessarily. If you want to be specific about it, we say skip a meal and maybe breakfast, and then keep on checking the blood sugars every 2 hours while you're skipping it. And if your blood sugar rises 30 milligram per deciliter or drops 30 milligrams per deciliter every 2 hours, then your basal insulin needs adjustment.
When we start insulin treatment on a patient, I remember there's something called the honeymooner syndrome. Can you talk a little bit about that?
Yeah. So when we come with type 1 diabetes, that means that we lost 80% of our islet cells that produce insulin in our system. There's 20% that may be still present, reserve of some sort of insulin. And after you start treatment, that 20% may kick in and will start producing insulin, a good bit of insulin, that may make it easier to control the diabetes, and that's why we call it honeymoon. It's like a newly married couple and having a very good time. It's not because they eat honey all the time. And they have relatively easier to control blood sugars. Their needs of insulin are much lower than expected per weight that they have. And this honeymoon can last up to 6 months, but even up to 2 years or 3 years. So we've had some patients that we're treating that continue to have some level of insulin production a good bit of time after diagnosis. It disappears. One thing I worry about the honeymoon is that when it goes away, there's panic in the family and in the child that the child is starting to do something wrong and blame game going on. So I keep on reminding them, you're dealing with easier to control diabetes. And that may go away, and don't panic if that happens or when that happens.
Got it. And for these patients who are on chronic insulin for their lives, how do you counsel about hypoglycemia, the risk of hypoglycemia, what to look out for, and how bad is that?
Yeah. So the first thing that we teach them is that a blood sugar below 80 or below 70, they should consider it low. Although physiologically speaking, many people who don't have diabetes walk around with numbers below 70 and below 80. And the reason we say that is in order to have a buffer of protection against the scary low blood sugars, which are like the 50s and the 40s and below that. So what we tell them is that you really want to try to avoid numbers below 70 or 80, but certainly you should not have blood sugars below 50 more than 2 times a week or 3 times. If you do have blood sugars below 50 that often, then we need to do something in order to avoid it, make adjustments of some sort. What we want to try to avoid is getting into what we call neuroglycopenia, which is translated as low glucose in the brain, and that's when you have seizures, problems with level of consciousness, talking out of your mind, very poor judgment. So that's kind of our aim there. That has been helped lately by using the continuous glucose monitors, and most insurance companies, including Medicaid, will pay for continuous glucose monitors for people who have significant low blood sugars that they may or may not feel. There are symptoms for low blood sugars like sweating, but that doesn't happen in everybody. And so we teach about them, but we also tell them to be vigilant all the time.
Are there other symptoms that, or mild symptoms that they should be looking out for that you tell them, if you're seeing this, make sure you try checking your blood sugars at that time?
Like palpitations, cold sweats are the main things. Tremors would be one of them. The main cause of those symptoms is our sympathetic nervous system kicking in, and that's what's doing it. So that's the low blood sugar stimulating our sympathetic nervous system that's doing this, and that's when you're having a rapid drop in your blood sugar.
So once they're low, how do you counsel them to treat it?
We use the rule of 15-15-15, which is meaning you give 15 grams of carbohydrates, and then you wait 15 minutes, check the blood sugars, and if it's still low, you give another 15 grams of carbohydrates and keep on doing it that way. Sometimes they will get sick of that because it takes forever, and many people when they are low, they just want to eat the whole world before, which leads to another problem of a rebound high.
Now, do you ever, I know parents maybe carry cake frost, like a tube of cake frosting or glucose gel, or when should people routinely have those? When should they have like a glucagon pen? When would you see those types of treatments?
Yeah, so the glucose gel and the cake icing would be something that oftentimes people use for someone who's showing decreased level of consciousness and would not be very good at swallowing, and therefore you're aiming for the glucose to be absorbed in the oral mucosa. You can use glucagon anytime in situations like that. People try to avoid using it unless you have a seizure or something like that. But there is something that we use often in someone who's unable to eat or drink but not having seizure, and that's what we call mini dosing of glucagon. And so you reconstitute it, and then you give a unit per year of age for the patient subcutaneously, and that raises their blood sugar enough to proceed further. Now, glucagon is now available in an inhaled form, so that can be used as well.
Huh. I didn't know that. I am not diabetic, but also carry around emergency cake frosting just in case.
Well, I will not judge that.
I appreciate it. So let's say our patient gets under control, understands their insulin regimen, understands how to monitor for hypoglycemia, and is relatively well controlled. But now that he's got the hang of it, we want to talk about some of these other contingencies. So what about when he's at soccer practice or doing really intensive athletics? What about when he's sick? Or what about if he's a young adult, if he's taking in alcohol? How can these things affect the glucose and how he should be dosing insulin?
Yeah, so sports. Sports is interesting because it can do two things to us. One of them, it may increase our sympathetic tone, and that actually can raise our blood sugar a little bit. But then we're also increasing our aerobic activity, and that will lead to our muscles to consume more glucose. But our muscles will not consume more glucose if there is not enough insulin. So the first thing about sports that we advise is if your blood sugar is very high, then sports is bad. And you don't want to go to sports if your blood sugar is above 350 because you worry about there is not enough insulin in your system, and that sympathetic nervous system may actually raise your blood sugar further. So if blood sugar above 350 or present ketones, no sports. Blood sugar below that, you may consider it. So what we tell them is that with sports, sometimes you may have high blood sugars in some people, and sometimes you will have low blood sugars. The more common is the lower blood sugars, but higher blood sugars can happen. What we also see in sports is a delayed effect where a few hours later, you may start having lower blood sugar. So if you had a very active day, we say during the night, you really want to check your blood sugars a little more often because you may run into lower blood sugars at that time. I met one time with an elite athlete who said that he actually gives himself extra insulin the day of a tournament, even without eating, because all that stress of the tournament raises his blood sugars even without eating. But then he will have to check his blood sugars very often.
And how about someone who just gets sick and has a bad cold and maybe is eating a little less?
Yeah. So blood sugars can rise and go down or go up, with sickness because of the stress hormones that can raise it, or because you're not eating. The main thing about it is that we say you really want to make sure that you're having basal insulin on board. You don't want not to give insulin. You always have to have insulin in your system. And then you have to check more often and perhaps give yourself more often insulin, or avoid some of the boluses if your blood sugar is tending to be more towards the low end.
So to piggyback on that, so obviously when we take care of kids who are admitted to the hospital, what is your general rule of thumb in treating their insulin, say if they're going to have a procedure or if they're not eating? How do you approach that scenario?
Yeah. For procedures, what we advise is that the NPO after midnight does not apply to clear liquids. So we allow them to continue drinking clear liquids to treat lows or highs up to 2 hours before the procedure. So yes, you don't want to eat solid food, you don't want to drink milk, but you can use clear liquids if you're dealing with a low blood sugar or a high blood sugar. And the second thing that we say is that we advise the surgeons to put them as the first people on that list, so they will have the surgery right away. And then when they come to the unit where they were going to have the procedure, put an IV and make sure that their blood sugars are checked every minute in order to make sure that they are in good shape.
Now, do you ever cut their basal insulins during this time?
Sometimes we do, sometimes we don't. We do it if we're thinking that they are overdosed and their basal insulin. But if we feel that their basal insulin is ideal, then we just stay on the same one. If we are to decrease the dose, then we decrease it by 10 to 20%.
And so it sounds like a general theme, whether sports, sickness, or other things that can affect glucose, is just monitoring more closely.
Correct.
Is that fair to say?
And because of that, a very important goal for me as a physician that treats people with diabetes is give them as much autonomy as possible and give them general guidelines, but I want them to be the ones who are controlling and really teaching me about how they are dealing with those things.
What are we worried about in type 1 diabetes that go untreated? If someone has high blood sugars consistently, what are the complications and side effects of type 1 diabetes?
Yeah, so we have vision problems, neurological problems, cardiovascular problems, kidney problems, and may end up leading to renal failure. And this depends on the hemoglobin A1C, how high it is and how persistent it is. So, and this is a very important question because, like, sometimes will call me in a panic because I have 300 blood sugar, the damage is happening. My kidneys are gone and all that stuff. No, calm down. That's not the case. This is more of something persistent for years and years and years to come. So I advise them about that. They want to try to have as low a hemoglobin A1C as possible, but without running into too many low blood sugars. But not to panic if they had one high hemoglobin A1C, and aim for the long-term effect, because it's something that's more cumulative. But certainly they need to be aware. That's why they have to have an eye exam once a year. We have to check their cholesterol and lipid profile every year. We check their kidney function and their spillage of protein in the urine also once a year. So we are, as part of management of diabetes, we are monitoring for those kinds of things on a regular basis. Where I am weak at is catching neurological manifestations or peripheral neuropathy. I worry that I may be missing some milder forms of it at times.
And this is all because the glucose itself in high amounts is toxic to cells. Is that the pathophysiology of what's causing the disease?
So the thought is yes, like the persistent presence of glucose in the cells at higher amount than usual is going to glycosylate certain proteins in the cells, and that glycosylation of the proteins in the cells is causing to damage, leading to some damage.
Got it.
So you were saying that you want them to have as low hemoglobin A1C as possible without low sugars. Are there goals for the A1C right now that you generally go for?
Yeah, so for the very young, for the toddlers and stuff like that, we tolerate an A1C up to 8.5%. But as they get older, then we start getting closer to the ADA guidelines, which is aiming for an A1C of about 6.5%. Now, as I do that, I have to keep in mind that in type 1 diabetes patients, that may be a goal that's very, very difficult to achieve. And so as I tell them what is the ideal hemoglobin A1C to have, I also have to keep in mind not to make them panic if they have a 7.5% A1C, because it may be very difficult, or it may be associated with too many low blood sugars to get an A1C to 6.5%. Our newer tools of managing diabetes are helping us get closer to that goal. And so maybe it's not a problem in the coming few years, but it was a problem through my career.
You mentioned the continuous glucose monitor, and you mentioned the insulin pump. How close are we to connecting those to make a robot pancreas? Will we have cured type 1 diabetes by the time this episode comes to air?
We will not cure diabetes by the time it comes to air. I am so sorry about that. But the closed loop system is already present. The closed loop system is having a continuous glucose monitor. And for those who are not aware, continuous glucose monitor is a device that's in the subcutaneous tissue that checks the blood sugar maybe every 5 minutes or so. And this continuous glucose monitor is now connecting to insulin pump and giving the orders to the insulin pump to give more insulin or less insulin depending on the trend of the blood sugar. If it's rising, then the pump will give more blood sugar, more insulin, and if it's dropping, then the pump will give less insulin. So that's already present. It's not yet ideal. I mean, there is more adjustments that we need to make in order to have more reliable systems, and the patient still has to bolus for their food. If they don't bolus for their food, there may be a problem, like a rapid spike in the blood sugar, and then the pump will panic and say, well, there's something wrong, and you have to deal with it. And so that's an area where we are. But over the coming few years, I think that will become the standard of care, a closed loop system of some sort. And if a pump company is not doing it, then they're going to be out of business maybe over the coming 5 years or so. The search for the cure is ongoing. It's a hard one. We're trying to, where is it? Can the islet cell regenerate? So there are some researchers at University of Alabama in Birmingham that believe maybe the islet cells can regenerate if we give them a break from the immune system, that the immune system is not attacking them that much. And then the potential for, can you use maybe a stem cell and put it in the islet cell and therefore it will regenerate? The biggest challenge that we have is how to manipulate our immune system in a safe way in order to counteract the autoimmunity that is really the factor in type 1 diabetes.
Well, I guess with that glimpse in the future, Justin, I think maybe we should wrap up.
I think it's a great idea. Hussein, if you could ask, what are the big main take-home points you want our listeners to walk away from this episode with?
Is that the management of diabetes over my very long career, I'm not going to show you how old I am, is that every 5 years, there have been a revolutionary change in the management of diabetes. Every change had been more positive than the other and more positive than the other. So keep yourself tuned to what's going on. And the other one, and that's very, very important, we can look for the cure, but the most important thing is to help people live a happy, healthy life. And part of a happy, healthy life is to be involved in a community of people that have diabetes or have interest in managing diabetes that can provide patients with a sort of support system and an empowerment system in dealing with this condition, because it's challenging and it's demanding and it can be a pain.
Thank you so much for coming on. It sounds like we have a lot more diabetes, and probably we need to have another episode. Don't you think, Justin?
Absolutely. And maybe a DKA episode. I mean, there's a lot more we can talk about.
Shut up. I mean, yeah.
Thank you so much. We really appreciate it. Anything that you would like to plug or anything that you would like our listeners to know about that they can follow up with?
I like diabetes camps. If someone is living in an area where there are diabetes camps, I think those are really great. Those are great for patients and for their families, but they are actually great for any healthcare professional, whether physician or nurse, who wants to learn more about diabetes. Then maybe volunteer some of your times at a diabetes camp, because that's actually how I learned more about diabetes than any other place. Because I worked with them as human beings, not as patients. That's
amazing. I love that.
All right, awesome. Well, thank you so much for being on.
Thank you, guys. Have a good day.
All right.
Bye. This has been another episode of the Cribsiders.
It's for the kids.
Get show notes at thecribsiders.com/podcast and sign up for our mailing list known as Knowledge Food Formula Feeds to get our weekly show notes in your inbox.
We're committed to providing you with high-value, practice-changing knowledge and weight-based dosings of fun. To do that, we need your feedback, so please subscribe, rate, and review the show on Apple Podcast, or contact us at thecribsiders@gmail.com. A special thanks to our assistant producer of this episode, Shannon Snellgrove.
Thank you guys so much for joining us tonight. I have been Justin Lee Berk.
I've been Shannon Snellgrove.
And this has been Chris the Chew Man Chiu. Thank you and good night.
Hey, you've already listened to the entire episode. Now claim CME credit. Continuing education credit is provided by VCU Healthcare Continuing Education. VCU is accredited to provide continuing education to the entire healthcare team. Check it out at cribsiders.vcuhealth.org for more information and to claim your credit after listening to this episode.